Thank you for inviting me to do this presentation on palliative care. This is organized by National Cancer Control Program and the Ministry of Health for the benefit of medical officers and nursing officers to increase awareness of palliative care professional society. So we are going to discuss the definition and core concepts of palliative care and the need for palliative care and who should receive it. Since we are going to discuss today. And before everything, we would have to ask this question from ourselves. Why do I need to learn palliative care? Because access of palliative care is a human right. Access great need, but there are limited resources only to receive palliative care. Even healthcare professionals may have limited awareness or knowledge of palliative care among our health professionals. As I told you, so this is a human right. Receiving palliative care is a human right. Limited resources, although the great need is so much. And making everybody aware is very important in this important subject. To support this, WHO has given some facts. It says, palliative care improves the quality of life of patients and their families who are facing problems associated with life-threatening illness, whether physical, psychosocial, or spiritual. So that is, just look at it, that it improves the quality of life of patients and families who are facing the problem associated with life-threatening illness. Each year, an estimated 40 million people are in need of palliative care, but out of them, 78% of them live in low and middle income countries. So it is very important to us Sri Lankans. This is the sad truth. Worldwide, only about 14% of people who need palliative care currently receive it. Actually, we should try to increase this figure by making more awareness and establishing new palliative care units in our small country. And the other fact about it is, overly restrictive regulations for morphine and other essential controlled palliative medicines deny access to adequate pain relief and palliative care. So this morphine use, if it is overly restrictive, actually it has to be, the morphine use has to be restricted. It is a restricted medicine, but overly restrictions will deny the access to adequate pain relief. It has to be available. And further, it says, lack of training and awareness of palliative care among health professionals is a major barrier to improving access. So it's a major barrier. That is why the Cancer Control Program and the ETR unit is trying to do some awareness training programs like this on this important subject. The global need for palliative care will continue to grow as a result of the rising burden of non-communicable diseases and aging population. I hope you all understand that aging population is getting more and more. So the non-communicable diseases, including cancer, numbers go up and up. So that means the need for palliative care continue to grow. So we need to know about it more and more. Early palliative care reduces unnecessary hospital admissions and the use of health services. So mind you, this is very important. If somebody is having and attached to a palliative care unit and receiving palliative care, admissions can be limited because when patient just go home and then they get uncontrolled pain, they frequently get admitted, and uncontrolled symptoms like SOB or vomiting. So the relatives tend to admit the patient for just to for the symptom control. But if the patient is on proper palliative care follow-up, so they can actually, they are given PRN medications, they can actually contact the hotline of the palliative care unit. So actually, so no need to admit, the admissions can be reduced very significantly. If you look at the palliative care requirement, the WHO statistics, cardiovascular diseases require 38.5%, cancer requires 34%, chronic respiratory diseases 10%, AIDS 6%, diabetes 5%, kidney failure, chronic liver disease, multiple sclerosis, Parkinson's disease, rheumatoid arthritis, neurological diseases, dementia, congenital anomalies, and drug-resistant tuberculosis. So these are these diseases need palliative care at the end. You would have noticed that the cancer is just 34%. But mind you, when you look at practically in most of the palliative care centers worldwide, the patients who are registered, more proportion is cancer patients. Why is that? Because everybody, when they get an incurable cancer, family and the patient, everybody is very willing to accept that it is incurable. Everybody, without question, they accept when a doctor says that this disease is incurable. But in the conditions like chronic liver failure, diabetes, AIDS, and those non-cancer cases, they don't really try to accept, and as well as the clinicians don't really try to convince that these diseases are incurable. So they seek palliative care and they are referred to palliative care quite late. Look at pain and opioids in palliative care. Pain is one of the most frequent and serious symptoms experienced by patients in need of palliative care. Remember any occasion that you got pain? I suppose everybody had at least one episode of pain during your lifetime. So it is so important to control pain. Why? Pain can cause, if you have pain, you can't eat. If you have pain, you don't like to talk to others and communicate. If you have pain, you can't sleep. So body, if you are having pain. So the pain has to be controlled. Opioid analgesics are essential for, if you take AIDS and cancer, it's about 80% of AIDS and cancer patients experience severe pain at the end of their lives. But less than that, 67% will have severe pain at the end of their lives. However, you need to consider either cancer or non-cancer. So I hope you will get a lecture presentation on pain control later on. Can also alleviate other common distressing physical symptoms, including breathlessness. Have you ever heard of that? Morphine is used to treat breathlessness, used to treat SOB and dyspnea, SOB dyspnea in patients with cancer and also in COPD to be used morphine. Controlling such symptoms at an early stage is an ethical duty to relieve suffering. Ethical duty. We just can't look at somebody, if somebody is suffering in pain or any other symptom, we just can't look at and empathetic. We have to be compassionate. We have to try and solve the problem as much as possible of everybody. Because of all these reasons, the WHO came up with a global resolution on palliative care in 2014, the first ever global resolution of WHO, WHA 67.19 called upon WHO and member states to improve access to palliative care as a core component of health systems, with an emphasis on primary health care and community or home-based care. With this resolution, every country had to compulsorily start palliative care in their own countries. Actually, in our country, we started a little bit before this with the National Cancer Control Program and the Ministry of Health organizing palliative care trainer program. And as a result, we have started palliative care consult service at National Cancer Institute, Maharagama, in 2014 or 2015. Principles of palliative care. What are the principles? Palliative care is a holistic care. It is care of whole person, not just a symptom or a complaint. You remember when you give the Hippocratic oath, when you become registered as a doctor, you say that Hippocratic oath say, don't treat for cancerous growth or a fever chart, treat the whole patient. That is the holistic care. Are we treating only the patient? It's not only the patient, the family and the carers as well. Is it surprising to you? All these days, we think we need to treat patients, but in these cases, the family and the carer is also have lot of issues. We need to look after their issues as well. Just remind any occasion that a family member of your family member getting sick, and when you or somebody or other one in the family had to look after the patient, become a carer, it is very difficult. They exhaust physically, they exhaust psychologically, they exhaust financially. These things need to be addressed by healthcare professionals under this topic, the palliative care. As any other medical term, the palliative care also has a WHO definition. It's a long one. I will give it in step-by-step manner. Palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. If you look at this, just concentrate on the phrases which are colored. A quality of life of patient. We are talking about quality of life of patient and their family, life-threatening illness, relief of suffering, early identification, assessment, treatment of what are we treating, physical, psychosocial, and spiritual. Mind you, here it is given as psychosocial. Later on, this psychological and social has divided into two. If you look at their needs, the needs of a palliative care patient, as we all discussed now, this is just a summary. They have physical needs, they have psychological needs, they have financial and legal needs, they have spiritual concerns, They have information needs, they need a lot of information, they need social support as well. If you look at this financial and legal needs, financial, okay, what is legal? They need legal needs. Just think a bit legal needs in a patients who are having an incurable illness. Think about their legal issues, their property management and all that, their bank loans and things. So they need to be managed. That is also part and parcel of this delivery of this care. So we discussed, this is a summary, the 4 domains of palliative care. This is the famous 4 domains of palliative care: physical, psychological, social, and spiritual. Then we look at when to start palliative care. Whether it is after conventional treatment or at the beginning of diagnosis, whether to start after conventional treatment for the incurable illness or at the beginning of diagnosis of an incurable illness. Now, give a little thought to this. These are the models. Conceptual shift of palliative care. Very old model is you first start life prolonging care and then give palliative care. But the newer model is at the diagnosis, you start life prolonging care and the palliative care together. With time, the palliative care component goes up while life prolonging care component goes down and becoming narrower. And finally, the terminal care is the only thing we need to deliver before the patient's death. And just what is this triangle after the patient's death? Hope you remember I told you the family is also part and parcel of our care. So we need to care the family after the death of their loved one. That is bereavement care. So we need to look at their psychological issues and any other psychological, social, physical, all that after the patient's death for a given period of time until they become psychologically okay. This is again palliative care enhanced model. This is actually developed. This is also called bow tie model. This is developed to when you are describing when you are giving information on palliative care to your patient. So when you try to explain what palliative care is to a patient, because in our previous models, it just it talks about only death. So patients might get upset if you just talk about death straight away. So this bow tie model is to dilute that thought. The disease, this is like this is, if you show this is disease management in blue, slowly tapers off, pain and symptom management slowly increasing, and at the end, either rehabilitation and survivorship, or if the patient survives in very rare case, and it's palliative care, hospice, palliative care unit, end of life care is also increasing at the end of their disease trajectory, and the bereavement care lastly. If you look at the misconceptions of palliative care, so there are people believe the palliative care, so sometimes they don't really they don't like to talk about palliative care, and because usually the palliative care is intermingled with death, everybody fears that, as we described in the previous slide. There are so many misconceptions when we are talking about talking to a patient. We need to alleviate these misconceptions of palliative care. Therefore, you all need to know what these things are. Palliative care is this is a misconception. Palliative care is only for those who are dying. Actually, palliative care is not only those who are dying. This is a very misconception. Still, our clinicians think that the patient need to be referred to palliative care when they are at the end of life. When they are gasping, they immediately call the palliative team and ask them to come and see that they are the palliative team doesn't have anything to do. And so that's the palliative care is not only for those who are dying. Palliative care is only for those who have no chance for cure. Look at this. So palliative care is only for those who have no chance of cure. Yes, it is incurable illness, but this incurability and curability is very subjective. Even we have experienced that patients I have as an oncologist referred to palliative care. I thought initially this is incurable, very massive cancer and lots of symptoms, and he received palliative radiotherapy and the patient completely cured afterwards. The tumor completely responded and cured. So actually the patient doesn't like to come to our clinic. They like to go to palliative clinic because he is looked after very well with the symptom control and talking and more communication than in the oncology clinic. So we can't say there's no chance of cure because we are continuing the disease-modifying therapies along with the palliative care. Palliative care means giving up hope. Actually, palliative care doesn't mean giving up hope. It develops more hope for a better, comfortable life until the natural death. Patients who choose palliative care die faster. Patients who choose palliative care die faster. No, there are, even to disprove this, there are studies. Patients with non-small cell lung cancer metastatic cases, they have given the two groups. One group received palliative care and the normal oncological care, and the other group received oncological care alone without palliative care support. So the group who received palliative care along with the conventional care, they have shown that they lived 3.5 months median survival than the patients who received only conventional care. So that's a famous study in palliative care. So that doesn't say that they can die faster. There can be the death can be prolonged, but it's not hard and fast. We are not aiming for a hastening death or a postponing death. We will discuss that later. The other thing is the pain relief from palliative care creates addiction. Pain relief from palliative care creates addiction. If the patient this is the worst fear among healthcare professionals. Even the doctors prescribe morphine 4 hourly. The nurses scared to give 4 hourly. They try relief opioid medications. As long as the patient having pain and the dose of morphine is adequately titrated to the level of the pain, we look at, so go away the misconceptions. Now we learned about misconceptions. Now we learn about what are the concepts of palliative care. provide relief from pain and other distressing symptoms. Palliative care provide relief from pain and other distressing symptoms. We talked about it so many times now. And also, palliative care affirms life and regards dying as a normal process. So we accept the normal death. Integrating psychological and spiritual aspects of the care to the normal patient's care. And palliative care support patients to live as actively as possible. This is very important. So there are instances that some young patients with cancers receiving palliative care, they want to get married, wear the bridal dress and get married. So need to arrange that. Some kids say that they want to go to school and sit with the colleagues and study, go to school. So that type of things we need to arrange. So we have to support them to live actively as possible. And we have to control their symptoms so that they can do their ADLs, activities of daily living by their own without much support. That is very important aspect in our management. Okay. Provide support to family during their illness and the bereavement. Do you think what are the support family needs? When somebody is sick in the family, they don't know anything. They don't know anything about the disease. We need to give them the information. They don't know anything about how to look after the patient. We need to teach them how to look after, and they get upset. Their psychology go down, and we need to support for their psychology. They sometimes get financially burdened, so we need to try to support in that way as well. It is very important. Enhance the quality of life and influence the course of the illness. It enhances the quality of life and it can influence the course of the illness. Palliative care is applicable early in the course of the illness alongside life-prolonging therapies. It uses multidisciplinary team approach. Always, one person can't do. A multidisciplinary team should do this work. The palliative care consultant is the team leader, and any other specialist doctors, nurses, minor staff, and all other speech therapists, physiotherapists, all other allied health, pharmacists, and not only those professionals, but the clergy and volunteers, that community support groups, everybody has to team together to deliver proper care to patient. As we discussed earlier, palliative care neither hasten nor postpone death. Treatment aim is not for cure, not for prolonging life. Treatment aim is to reduce suffering. You know what is euthanasia? Euthanasia, some people say it is mercy killing. Euthanasia is when anybody is having an uncontrollable symptom, severe pain and severe symptoms, so they hate the life, so they want to end their life to see an end to this suffering. So they say, doctor, it's enough, me suffering. Please give me an injection to end this suffering. So euthanasia, is it part of palliative care? Just think a bit whether euthanasia is part of palliative care. You may think yes or no, yes or no. No, it is no. Euthanasia is not a part of palliative care. You remember the previous slide. Palliative care neither hasten nor postpone death. Treatment aim is not for cure, not for prolonging life. Treatment aim is to reduce suffering only. And we need to look at this that graphic has a bit of a problem. It has changed, I think, with this software. So palliative care is the big. If you just imagine this circle is an oval like this, right? Including the whole, these two small circles is in the one big circle, that is the palliative care. And this light purple bigger circle is end of life care. We call it end of life care. That is when the patient reaches weeks to months to death. If the patient we think will die in weeks or few months, that we call that is end of life care. And the last bit of days to hours, if the patient just has only few days or hours to die, that period is called terminal care. These three parts of the palliative care, the management is different. We need to learn how to manage a terminal patient. Is not the way you manage end of life care and at the initial stage where we combine with the disease modifying therapies as well. And where can we give palliative care? We can give as inpatient hospital, government hospital or private hospital, or in hospice. You know what hospice is, I suppose. It could be given as outpatient clinic. It could be given in a home-based palliative care, because most patients, when they reach their end of life, they are difficult to transport to hospitals. So the team has to visit the patient's home and give the necessary support to have a good death. Nursing home and elders' homes, we can arrange it. Private hospital, as we mentioned earlier, emergency department and ICU. Just mind you that emergency department and ICU palliative care is a very specialized part of palliative care. We just can't, any doctor just can't say this patient is palliative unless it is a patient who is having a DNR order and already a palliative unit registered patient. So then can consult the palliative unit consultant and get the approval to say that patient need to be managed palliatively in the emergency treatment department. But if a patient comes with critical injuries which cannot be cured, so there are many consultants need to get together as a team has to get together and decide whether the management to be in palliative concept or a curative concept, if the interventions will be very futile for the patient. Then next we will look at how to deliver this palliative care to our patients. If we say that this purple triangle is the patients who need palliative care, there are 3 tiers how to deliver the care. The bottommost is the palliative care approach, which is delivered by all healthcare professionals. That is why we need to make aware all healthcare professionals about the palliative care. So they need to identify the patients who has these psychological, social, spiritual problems, and then refer to, if they can alleviate them, okay, good, you do it. If not, refer to somebody who can do that. So that is very important. Everybody in health, all healthcare professionals knowing, being aware on palliative care. Additional training. This second tier is the people, the professionals with additional training delivering moderate type of palliative care. And the topmost tier is the specialized setting with hospice and specialist in palliative care. There are in Western countries the specialist doctors and specialist nurses to deliver palliative care. So, if you look at this triangle, these topmost patients only specialized setting can be delivered to a small number of patients because it's only limited number of health professionals in a specialized clinic. But if all healthcare professionals can deliver palliative care to even a smallest extent, so the people who need palliative care at least get it in a minute or minute level. At least they get some sort of a care if these two tiers are active. So we have to take all our effort to improve these two tiers while improving this tier. For that, we are now in PGIMS in the process of making the developing the prospectus for the MD palliative medicine consultants to develop MD palliative medicine consultants. So until such time we can develop these two tiers so that all our people will receive palliative care. Initially, you remember I told you only 14% of people who will receive palliative is receiving palliative care currently world statistics, but we can improve by developing these two tiers. At least they receive some sort of palliative care. I'll show you how we do this. This, the same triangle, I would made it little bit elaborate. So this is the primary level area, and this is the specialized area, and this is the primary level palliative care. Most patients require only primary level palliative care or palliative care approach from a family medicine clinic, oncology team, internal medicine clinics, cardiology clinics, COPD clinics. So we need to, everybody, all the clinics can have some sort of a palliative approach to the patients who in need. And then the next tier is the patients may occasionally require assistance to a specialist palliative team as a shared care approach. Then small number of patients with complex needs, mind you, this is patients with complex needs require transfer of care to a specialized palliative service. So if you look at this patient, from the diagnosis, throughout the illness trajectory and death, the patient is satisfied with the primary care palliative care only. This patient B starts with primary palliative care and then goes up. His need become little complex, so he goes up to a specialized service, settle it, and then come back and continuously manage along in the primary settling as only. Then this patient goes up to the specialized level, and the rest of their life he need to be managed in specialized level. And this patient goes up, come back and manage at the middle level. This patient continuously managed at the middle level only. Few patients need continuous management throughout their illness trajectory at a specialized clinic. I think I have described you most of the things in palliative care. Thank you for listening to me.